want to say anything that is really crazy, don't say it anymore. So I just don't want to forget to start recording. So it looks like we have about 3 minutes. We have a collection of some individuals on the line. While we're here, I guess it would be great if I could hear who is on the line aside from the speakers, and I'll introduce the speakers. So 208-500-1115, who is that?
Hi, my name is Vanessa Carroll.
Excellent. And where are you from, Vanessa?
I'm actually from Coeur d'Alene, Idaho.
Cool.
Oh, that's gorgeous out there. Yeah.
Thank you for joining.
It really is. Well, thank you for inviting me. I greatly appreciate it.
And what's your background, Vanessa? Are you hospitalist, emergency medicine, pre-hospital?
I'm a hospitalist, so
cool.
but I have a vested interest in obviously really getting a robust community PZR going. So this is going to be, highly enlightening.
Excellent. And then I know who Mike Ely is. Mike Ely is from NEDARC. Thanks for joining us, Mike. And then I see Jason, who's from Geisinger as well. How about RNELLOR? Who's that?
Yes, my name is Roxanne Neller. I'm from Children's Mercy in Kansas City, and I'm the Assistant Director of the Clinical Services with the transport team.
Awesome. Thanks for joining us. Leonard?
Yes, I'm Leonard Pollack. I'm a pediatric hospitalist at Henry Ford Hospital in Detroit.
Thanks for joining us, Leonard. I have to figure out how to get a bigger group of thumbnails now, which is a good problem to have. So Emery, I know who you are from Tufts, Peds Emergency. Crystal Diaz, you just want to introduce yourself? Or Crystal Das?
Hi. I'm Crystal Das. I'm at Nationwide Children's Hospital, currently working as a general pediatrician in the ER and transitioning to PEM Fellowship this summer.
Excellent. So
we'll talk after.
So no recruitment yet, Chris, come on. So thank you so much to those that were nice enough to join early. So I'm excited to see that we already have 12 individuals on. We're gonna have a webinar today that is a part of our Pediatric Readiness Community of Practice. And for those that are not familiar with the concept of a community of practice, I just wanted to remind people that this concept is really a group of people who share a concern or passion. So in our case, it's for ensuring optimal acute care for ill and injured children. And that's what many of us do every day, whether you're a hospitalist, a pediatrician, a surgeon, an emergency physician. And our goal of these webinars, in addition to having an ongoing interaction with our community of practice, is to learn how to do things better and interact regularly and hopefully shamelessly borrow things from each other so that we can optimize that towards that goal. I do want to highlight for those individuals that have been involved in the community of practice just a really amazing story, and I want to thank Emery Petrak for this. So Emery brought up at the AAP during our section meeting that working with the hospitalist section and committee would probably be a wise idea. And working together with Emery, we were able to send an email out to the hospitalist section and committee of the AAP, and within 4 hours, we had 70 people registered to join the Pediatric Readiness Community of Practice. So I think it really demonstrates that there's a large community of pediatric hospital medicine providers with a real passion and interest in this. And it really was telling to me how many people signed up, and seeing some of you guys on the webinar today. Many of us that are on the call have been working on pediatric readiness for many years. If we sort of have things that go over your head in terms of the Pediatric Readiness Project, myself, Mike Ely from NEDARC, others that work with HRSA and EIC certainly were available. I will send out a link that will be to this webinar so that you could share it with friends or colleagues. And I think that will get started. I will remind people that I will likely mute your phones while you're speaking while the speakers are sharing, and then I will unmute. So our format for the session is to have about 20 odd minutes of didactic. Certainly if there is a question during the didactic, we find it really useful to use the chat function to ask that question, and we can collate those for later on, or I can moderate and interrupt the speaker. After that, we're really hoping that we can have about 40 minutes of active discussion and then continued engagement after this session. So I really want to thank our speakers for today. We've had 2 prior webinars, and we've really tried to make these webinars both pragmatic and useful, as well as diverse. So today I'm really excited to have 2 speakers, Sarah Ellender and Chris Valenti, and then at the last minute, Chris was kind enough to, and Kara was kind enough to join us, where we'll have a number of perspectives from both physicians and nurses. Kara does have photos of herself, but Chris made this last-ditch effort to make sure that we engaged a nurse, which I really appreciate, and thank you, Kara, for showing up at the end here. So I'll start with Sarah. Sarah came to Geisinger Health System, which she'll be speaking to today, in 2018 as the first director for pediatric emergency services across their health system. Prior to that, she had served as the chair of pediatric quality and safety at Children's Hospital in St. Louis, and she also staffed the peds emergency department there for 14 years. She was in Kansas City for 8 years and did Penn Fellowship and a clinical pharmacy fellowship as well. So has lots of backgrounds in pharmacy, quality improvement, pediatric emergency medicine, and now a role within administration. She received her MD from Michigan State and did her residency at Butterworth, which is now DeVos Children's Hospital in Grand Rapids. And then she worked in private practice actually for a number of years as a general pediatrician prior to going to fellowship. Thank you so much, Sarah, for joining us. We also have Chris Valenti, who is a chief of the section of pediatric emergency medicine at Reading Hospital, which is a part of Tower Health and affiliated with the Sidney Kimmel Medical College at Jefferson University. He's been out at Tower Health since 2016, came there right out of pediatric emergency medicine fellowship at CHOP and did his residency at Hopkins. I actually knew Chris as a medical student when I was a fellow at NYU. We played basketball together, so things come full circle here. That was 12 years ago now. Chris graduated from NYU School of Medicine, and then Fordham College, was a valedictorian there. And his research interests are also quality improvement, and has a advanced training from University of Pennsylvania in epidemiology and biostatistics, as well as training from the Intermountain Group related to their healthcare delivery and quality improvement. He is nice enough to join us today, even though he does have a 4-month-old at home, in addition to his 6-year-old and 3-year-old. So thank you so much for that. And then Kara Gagliardi is a master's trained nurse that works together with Chris in the pediatric emergency department, is also the interim unit director for critical care transport. So with that, I will turn things over to Sarah and Chris. Just in terms of trying to stay as an education session, we do have 3 objectives. Really the first being, after this session, you'll be able to understand how pediatric readiness can be used to develop uniformity in care in rural health systems, to understand how Pediatric Readiness Project can be instrumental in the development of a de novo PEDS emergency program, and then lastly, to report 4 barriers to improving pediatric readiness across a health system or hospital and strategies to address them. So thank you so much, and I'll pass things over to Sarah to begin.
Okay, let's make sure I can do this.
Hold on, I gotta hit the remote control. Let's see if that works. You should be able to do it now.
Okay, so I click on this. Click now. So I want to go back one picture here, just make sure I can control it. Can I control it?
All right, I'll just do it for you, Sarah. Oh, you got it there. See if
I'm controlling it. I think I'm good. I think it says
okay, great.
I think it's just hit enter here. Okay, well, as Mark said, I'm at Geisinger Medical Center, which Business Week calls a healthcare system hidden in the heart of Pennsylvania. And that is a picture, I think it's the most current picture I could find of our hospital. Down in the bottom right corner of that hospital, you see this thing that's sort of a different geometric shape, and that's actually the Children's Hospital. So this is a place that is in a town of about 5,000 people. There are about 30,000 employees, last I read, of the healthcare system. It's not going forward, so you might have to do it. It says I'm controlling it, but there we go. So this is where we're located in the state of Pennsylvania. And the light blue is considered our entire service area. It's a 45 county area, about 3 million people. It may be a little difficult to see, but the little red X's are our hospitals, and I've pointed to where our main hospital is. The majority of children live up Luzerne County and Lackawanna County. So it's like to the right and up of where you see our hospital. And then next slide. Is that working? I think it's going to have to be you, Mark. I don't know. It's not working. Next slide. Okay, so this hospital was built in 1915. There was an iron magnate who had a widow named Abigail Geisinger, and the legend goes that she got a little tired of being one of the only people in town with a car and driving all of her friends down to Philadelphia to go to the hospital. So she actually got the Mayo brothers to come out and built a Mayo model hospital. So it's an integrated multi-specialty group kind of thing. Currently, the hospital has 544 beds, and it is also now an integrated system in that they have their own administration payer provider, so they have their own insurance product. It serves as an education center for residents and fellows in 28 specialties. The next slide. And then 25 years ago, they built this Janet Weiss Children's Hospital. And that is a level 2 pediatric trauma center. There's 91 total beds, 41 NICU beds. There's a 14-bed PICU. There is a pediatric residency that has 11 residents a year. There's a med-peds residency with 5 a year. And then Dr. Crellin, who's on the line, he and I actually work under the Department of Emergency Medicine, where we have 9 residents a year. They also run their own Geisinger Life Flight with 9 helicopters with 6 bases, and that serves the 45 county area. Next slide. So the differences that I noticed right away as I was visiting, and oh, it says my internet connection is unstable, so let's hope this works. Different for me is that I had never worked in a place where when somebody codes in the emergency department, they call an overhead code and the pediatricians come running, and it's the pediatricians from our PICU. The other thing that they had figured out as a workaround, because there was no PEDS-ER, is that many of the children are directly admitted to PEDS and to the PICU, and they just bypass the ED altogether, with the pediatric hospitalist taking the phone calls and when necessary, the PICU getting on the phone call. And then the kids who do show up in the emergency room had a very slow throughput because they were relying on the PEDS residents to see them. So they'd come to the emergency room, and my little joke is they would see and they would say, oh, you're under 18, we'll get a chest x-ray and we'll call for a PEDS consult. And, you know, without a whole lot of consideration for dealing with them in the emergency department without help. And then again, the PICU responds to all the trauma activations. So I'm ready for the next slide. So as I was looking at this, full disclosure, I was not looking for this job. I was in St. Louis, quite happy with what I was doing, but my husband actually was working for Geisinger. And so I was asked to come and look at this, and I was looking at all of, okay, you have a lot of interesting workarounds for not having an ER. And one of the interesting workarounds was looking at their trauma quality data. What this slide is showing is that before there was any semblance of a pediatric ER, their risk-adjusted major complications from trauma in children was lower than the national median. So, you know, I kept saying, help me understand why you want a PEDS-ER. It looks like you figured out some pretty decent workarounds. I'm ready for the next slide. So as I looked more at what they had a very well-developed informatics program with its own fellowship, and they've been on Epic since 1995. They're one of the earliest adopters to Epic, and actually own their own data, where now when people are joining Epic, they can't do that. They have a very well-developed telemedicine stroke team, and so there is an infrastructure of about 24 people running a telemedicine program that was kind of primed for growth and looking at a different way to use telemedicine. And I made sure that before I came, I went back a couple times and kept thinking, I'm not sure you guys really know what you're asking for, because there weren't very many people there who had seen a pediatric emergency department. So I did meet with the CEO and wanted to make very sure that there was at least interest or willingness to develop a program. The leaders just above me, the EM chair and the PEDS chair, are very, very interested and very supportive. So those are sort of things that all seemed like, okay, these are the assets. I'm ready for the next slide. And then along came January 2018 when I moved there. Dr. Krellen had already been there for a few months. So we started with me, who's kind of old and has kind of had a circuitous career path with doing a bunch of different things. And then Dr. Krellen, who's trained differently. He's EM-PEM, straight out of fellowship, has an MBA, but also happens to be the smartest guy in the universe. And then we had a nurse who was assigned to us. And when she and I sat and looked at job descriptions of nurse coordinators, what we could come up with was that she had a lot of experience and she was interested. She actually didn't have a lot of formal education in pediatrics. So the first day on the job, I was trying to get my head around, okay, I need to connect this hospital that has all of these subspecialty services, and this is where, so it makes the most sense that this is where the ER is going to be. But our larger pediatric volume is actually one and two counties over, where we had two hospitals that are seeing roughly half of the PEDS ED visits. There's about 45,000 visits a year. So my second day on the job, the pediatric chair came in and he said, okay, I hope you understand, and you can go to the next slide right now, that this is your job. These are your hospitals and you need to figure out how to make this whole thing work. Okay, so I'm ready for the next slide. So I had actually spent a couple months really thinking about this hospital with the two other hospitals and thought, all right, the more the merrier. So I kind of took a four-pronged approach. The first one was we had to build a more complete PEM curriculum within EM and the PEDS residency program. And that is kind of assigned to Dr. Krellen, who's doing a remarkable job with it. So he's kind of our core faculty for the EM and does a lot of their lectures and a lot of their teaching. Telemedicine had been very interesting to me because I had come from Mercy St. Louis that has a large virtual hospital, and that actually was my next step in St. Louis had I stayed. And so I was very interested in figuring out how I could make that work. And then the other part that was very striking was that here's this hospital that's been on Epic for so long, and I thought, not a problem. I'd been a super user in St. Louis, and I thought I'm just going to show up and I'm going to just dump my panels in and I'm going to share them with everybody and it's going to be great. And the person assigned to me sat down and said, we don't have that functionality here. You can't do that. So that has taken a little bit longer. I had to go to Epic and become a certified builder, but that's okay. I think that really is an important part of how to connect all of these places. And then the last thing we did is we established something that I call the EMSC Council, which is Emergency Medical Services for Children. And that was going to be my four-pronged, these are the things I'm going to do in order to build this. I'm ready for the next slide. So with our telemedicine program, we're doing a hub and spoke model, meaning that we are the hub and we spoke out to a couple hospitals. We've been through a couple different software applications. Right now we're using InTouch platform, if that means anything to any of you. And we outreach to 2 hospitals in our system. And I'm actually not that interested in access to care because we have all of these hospitals. What I'm interested in is getting the kids to the right place at the right time. There's great variability in care in these other hospitals. And so we're largely using it to say, let us help you figure out if we can stabilize somebody there and keep them there and get them home, or if they need to come to us, and if so, what can I do on my end to either be very ready when they get here, or what can you do on your end so that a patient who in other circumstances would be an automatic PICU admit, we can get them enough better that we can get them to the floor. Ready? Our electronic order sets, our EHR order sets, a little bit different from what a place like CHOP has done where there's a pathway, is I have a lot of people caring for kids who have no pediatric background. So I need people to understand, oh, I'm looking at asthma. If I order a pediatric asthma set, can it help me? And so what we're doing is we're building an algorithm within the order set. So you click on it and it's like, here's how you do it. And this particular page, I know it's difficult to read, but the idea I'm trying to show you is that there's just an algorithm that's built in. So if you know what your problem is, then this kind of helps you. And then I have done, because I'm not trying to teach academically, I'm really trying to keep kids safe. If there are things that should always be done, they are pre-selected for people. So once you get into the order set, there are pre-selects that you have to do. And right now we've got 23 order sets that are in various stages of development. Got a way to go, but we're going to get there. And then the EMSC Council is really, I'm suspecting what this group is most interested in hearing about, because this pertains the most to the Pediatric Readiness Project. But patterned after the way we did Quality Council in St. Louis, where we were covering a 4-state area. We have a meeting once a month. I went to each hospital. I established a physician, I guess we could call this a champion in the Pediatric Readiness Survey. It's called the coordinator. But we identified a physician and a nurse at each hospital, and then it's turned out that the operations managers are quite interested in this. So at the moment, we have about 35 people on this council. On any given meeting, we usually have an attendance of about 20 people, and we've had a few times that we have not had representation from a particular hospital, but almost always everybody shows up. And our agenda, it took me a long time to figure this out, but our agenda is exactly the 6 points that are on the Pediatric Readiness Survey. So do we have something new to talk about who our nurse and physician coordinators are? Do you want to switch out? Do you want to stop? What do you want to do? We don't talk very much about number 1. Number 2, we've worked pretty hard on physician and nurse competency evaluations and figuring out what are appropriate competency evaluations to have. We've established some guidelines for doing some quality projects and some performance improvement projects in the ED. It turns out that a lot of this is right hand, left hand, not knowing what the other one's doing. When we've started looking at some of the things about patient safety and looking at radiation and imaging gently and all that, we discovered that the system really has all this stuff. It's just that the communication hasn't been out there. So we've been able to sort of have a central shared drive where we can say we really have gone through these things. Right now with patient safety, what we've done is our safety reporting tool comes to me weekly. We look for patterns. We talk in the group about that. And then we've also been able to go through policies, procedures, and protocols together. The very first day this started, one of the hospitals was late getting on the line, and they called me later and said, we're sorry we were late getting on the line. You were getting a transfer from hospital A that was supposed to come to us, and we were hospital B, and the child died on the way, so we had this code in our emergency department. So it ended up affecting our ambulance service and 3 of our hospitals, and it became a springboard for us developing death policies and what we're going to do and how we're going to do critical incident stress debriefing. And so from the get-go, it was a way to to have a combined group of people doing that. And then the other thing is that huge list of equipment and supplies and meds. We worked on a very basic list, and the very basic list that's there, and then we've worked with our pharmacy to figure out what makes the most sense for us. So what I've asked for everybody to do is I said, if you'll come for 1 hour a month, and initially I said maybe 1 more hour during the month, but I promised to do the legwork, could you please do this? And this has turned out, I've asked if people want to disband this group, and it's always been unanimous, absolutely not. This is the most meaningful hour of our month. So this has been a real success. I'm ready for the next slide. So when I was given this agenda, I had a very specific question of what has worked and what hasn't worked. And I don't think I can think about it that way, because if I thought about it that way, I would tell you there have been lots and lots of things that haven't worked. And I'm preferring to think about it as it hasn't worked yet. There's an awful lot of 2 steps forward and 1 step back, but this actually is one of my very, very favorite quotes ever from a movie that I keep telling myself everything will be right in the end, and if it's not all right, we're just not at the end yet. So I'm ready for the next slide. What has really worked is that I've worked for lots of big institutions before, and I'm very aware that you are kind of trying to turn a great big ship and being realistic about what you can do and what you can't do as a lower level person. I just think I'm a little bit more realistic about what you can do. But it is really striking to me how little obstruction I've had from administration. You know, Dr. Carlin and I are very much big fish in this pond, even though the pond may be fairly large. And so it is kind of interesting how I get asked my opinion, and for the first time, sometimes it feels like, wow, this is weird. My opinion really counts. We've been able to see 200 telemedicine patients. I'd like to say that number was a lot bigger, but the real striking thing is we wrote a pro forma on May 10th, and we opened a telemedicine project on May 26th, same year. It was ridiculous how fast the whole thing went. Approval from Department of Health, all kinds of stuff, because there was so much infrastructure there. Right away, we got an equipment list and did a uniform inventorying for purchasing so that there can be group purchasing, so all of that can be cheaper. And we aren't dealing with, you know, different everythings, so that we have a lot of doctors who work at 2 or 3 of these hospitals, and the equipment should all look the same and hopefully is stored sort of similarly. When we first started, there was 1 nurse there who had ENPC because she was so scared that she went off and took it on her own, because she just thought they don't know how to take care of kids here. We were able to internalize an ENPC course. We found a nurse in one of our hospitals who was just a couple observations away from being able to be a course director. And as of this month, we have 50 nurses who are ENPC certified, but we have another course coming up, and we will have 16 more within a month. So that is sort of, you know, exponentially growing. And we've also, I've been working with Mary Hagenbarth at Children's Mercy, who's advised me quite a bit. And we are able to establish the SPS course for our residents, hoping that our attendings will think this is interesting to do. The other thing that has just sort of happened organically, when I realized I wasn't exactly handed here's a check, go figure out what you need to do. The hospital does have a foundation, and we've been working on developing a relationship with the foundation. And actually, we've got 2 people assigned to us. And so we've been able to come up with money for remodeling a separate peds zone, and we will be opening a 9-bed separate area, hopefully in March. I'm used to using nitrous. That seemed like a novel thing here. We got a nitrous machine. We just last week opened 2 mannequins, and we also are getting some money from our foundation so that we can send Dr. Krellin off to become certified in sim education. And then I'm ready for the next slide. so not what hasn't worked, but what our challenges are is that some of the hospitals we're over have employed physicians. I think Team Health supplies a couple of them, and they just don't have any interest in participation. And that's been really a challenge because I've kind of jumped up and down and said, no, you really have to have somebody who's going to show up at this meeting, and you really have to have somebody who's going to help with this. But that's been a little bit of a challenge. We have a lot of emergency medicine doctors. We need to go back the other way if we could, who have just kind of said, I mean, it's almost a quote. I'm EM trained. I'm boarded to take care of adults and children. I don't need any help. And it is it is just a piece of paper to be PALS certified. That's ridiculous. And so I have no clout to do that when ASAP is saying they don't have to do that. So that's been an interesting challenge and trying to figure out a way around that. I don't have a way to enforce CME about children for physicians. However, that actually, because nitrous is considered a new service, I am figuring out a way to say, well, okay, you want to use nitrous, then you're going to have to take the SPS course, and you're going to have to do that. The 2 steps forward, 1 step back for EMPC. Our hospital where our director is perhaps separating from Geisinger, so I may be losing my course director, and it's like, okay, here we go. But I do have a handful of people who've made it through the instructor course, and so I've got instructors. And then we've got some acceptance barriers for telemedicine. That's been an interesting challenge. And we actually, because we're in the mountains, we've got some broadband limitations at one of our hospitals. But I would say our biggest challenge is there's 2 of us, and I'm having trouble recruiting. I feel like this is the last frontier in pediatric emergency medicine. And I feel like I've sort of done it all in my career. And it's like, holy cow, this really is kind of the most important and the last frontier. This is where all the kids are. It really is. But I would be lying if I didn't say that I don't get pretty tired. So it's tiring and all that stuff, but it's been a really interesting thing to say, wow, in 2 years, once I put it on paper and look at it, we've done an awful lot. And then my last slide, I think one of the other things we were asked is a very specific question about what input from pediatric tertiary care helps. And to be very honest, our team is a whole lot bigger than just the 2 of us. Before I ever started, I got in my car and I drove to all of those cities listed and visited all my friends who do PEM and said, I'm kind of thinking about doing this. What do you think I should do? I talked to Marianne and Patty about the whole PRS, because of course you Google, how do you start a pediatric ER in 2018? And the closest thing I could find was, let's use PRS as a roadmap. I sit on PEMNAC. There are some people there who've been very helpful. I think they look at me like, wow, you are really, really dumb. But they're super helpful. I am in St. Louis physically right now. I go back to Mercy quite a bit, and the people there have been very, very helpful. Mark, who is responsible for me being here today, is responsible for us getting started with SIM, and that's been super helpful. And then Mary Hagenbarth was a friend of mine when I was in Kansas City, and she has been, honestly, the first 6 months, I think I called or texted her something about once a week, just with a bunch of questions about freestanding children's hospital do this, because I can't remember because it's been so long, and she's been super helpful. And moving to the whatever part of the country this is, the Northeast, I really don't know very many people east of Ohio. And it has been really, really nice to be able to drive down to Philadelphia and meet with people and have easy help and easy collaboration. And so I just sort of think our team's really, really big. It just doesn't feel big. So that's what I got.
Thank you so much. That was really excellent, Sarah. Really amazing amount of work that you did in 2 years. For others, it would be an entire career, but really fantastic. And I think that a lot of really important information in terms of using the Peds Readiness Project as a roadmap. I mentioned earlier that we have some hospitalists on the call who might not be as familiar with that. I certainly am available, as is NEDARC, EIC, and HRSA to provide more specific details, and I'll send out a summary with access to that information for you. So now we'll pass things over to Chris to hear about the Reading Hospital experience. We didn't intentionally pick 2 hospitals in Pennsylvania. We were at the AAP special interest group meeting, and these 2 individuals, their work and their area of focus over the last few years was overlapping but distinct, and that's why we're really excited to have Chris give a similar but different story. Thanks, Chris.
Yeah,
Thank you, Sarah.
Great job, Sarah. And I know you feel tired, but I hope you also feel rich because you have 100% more PEMs than I do. No, but seriously, for the group, this is a small world, but Sarah and I just connected like a week ago, not even knowing, just with plans to talk about what's going on and share ideas, not even knowing that we were both talking on this webinar. I only realized it like 4 days ago. So it's a small world, share ideas, you know, and there's great fruit to be born from tiny seeds. So I think that's really, really an important lesson. And Mark, you know, when I decided to go into to PEDS-EM, all I really wanted to do was contribute to this great field, and I'm grateful to you and Teresa for giving me a chance to talk and hopefully do that. So all those times when the 6'5" guy was posting up the 5'6" guy, they're all forgotten. So so anyway, thanks. Yeah, this is our campus. You can move on to the next one, Mark. And that's where we're located, the largest Red Star in Berks County. So it seems like we're close, but we're actually worlds away. We're in completely different service areas. So just a little bit about our hospital. We're very old. We're very steeped in tradition. It literally has been. We just had our 150th anniversary. And it's very surprising when we tell people that we are among the busiest freestanding emergency, single site emergency departments in the country. We were 8th last year and largest in the state. Our annual volume, all comers, is over 130,000. And so the pediatric volume is about 1/5 of that. So we're at about 30 or so thousand. We're a very large hospital. I'd say we're definitely a tertiary care center, approaching quaternary care center in the adult realm. We just are developing a transplant service. We're a level 1 trauma center. We have 7 residency programs. We really are a regional leader in everything adult, and yet the spotlight has never really shone on the pediatric population. And we're hoping to change that. So here, my only purpose is to say, call yourself whatever you will. It really doesn't matter. Rather, just focus on the future and the opportunity that developing a pediatric emergency department can bring. We do have one privileged facet, I think, as pediatricians, that we care for kids, and you really have to be heartless to not get behind pediatric care, so we can appeal to emotion. So use that. Next one. So I'm just going to go through some lessons quickly, and I kind of set this up to move through. So so hopefully we'll spend no more than 9 minutes and then leave time for questions. And Kara's going to kick me to keep me on task here. One of the important things is that you're authentic in this endeavor. You know, the community will see through you right away if you market that you're a pediatric ED and you are not set up to actually provide high quality and family-centered care to pediatric patients. Next one. So when I arrived 3 years ago, the first thing we had to do really was just start to make a case to our administration that this is worthwhile. And you do that by visioning with people, by highlighting the fact that the care of kids is very nuanced and it is a specialty in and of itself. And the other thing that has been really important for us is because we are surrounded by pediatric hospitals, but because none of them are within 60 miles of us, it's been really inconvenient for families to receive critical care and subspecialty services. So we've really been able to leverage that point and take pride in the fact that now we can do a lot of things to keep people in their own neighborhood. So lesson number 2 is before you embark on this crazy journey, you really have to know that you're backed by important people. Next one. So it really is hard unless you have that champion. You need a champion. And I'm fortunate that I do. My chairman was past president of PAASEP and really well known in emergency medicine circles and in the community. And then the second is our chief medical officer who has a pediatric background. So that's been huge. And I'm not independently wealthy and I'm stink at raising money. So I needed those 2 people. You can't just rely on the good publicity. At some point, pulling on people's heartstrings isn't enough. And you really have to make a airtight case for, pouring resources into this. So we did population studies, we projected volume growths, we projected how much revenue we could bring into the system by starting to take care of children in the emergency department. Perhaps more important than buy-in from the C-suite is buy-in from your people on the front lines. That is everything, because when you're 1 or 2 PEMs, obviously you can't see even a fraction of those patients. Next one. So these are our team members, some of our core faculty, and I've been floored by how energetic my colleagues have been in taking on this, this project and stepping up to the plate and moving outside of their own comfort zones. I'm just really proud of our people and I am very grateful to Kara for being here. But where we have struggled in recruiting providers, we definitely hit a home run in getting Kara, and she can talk about the importance of the nursing side of this too. Do you want to do that now or later?
Sure, no, I can go for it right now. I think one of the things that we focused on was nobody to train the trainer initially, so getting experienced pediatric nurses into the emergency department was very important. We had lots of resources in the adult ED, but not a lot of people with peds experience, with the exception of Chris, myself, and our CNS. So we did end up getting one educator that does have some peds experience. She is also championed. She's now a course director for ENDC, so that is something. It sounds like we're about a step behind you guys over at Geisinger, but that's one of the things that we're hoping to implement within the next few months, as well as bringing certifications such as stable down from the NICU to our teams so that they can help provide the best care for that patient population.
Yeah, and we'll talk about some of the other things that we've done to kind of beef up clinical skills. But as Sarah alluded to, if team health was working our ER, I would not have moved my family to Reading. It would have been a fool's errand. We do have hospital employed emergency physicians who it's not to say that other physicians don't care. They do. They care about the well-being of others, absolutely. But there's something to be said for taking care of people in your own community and the accountability and the passion that comes along with that. And so our people were behind this from the very beginning. And there wasn't this tug of war of revenue. We're all trying to ensure that the hospital thrives. And the other thing is, you don't want people to just say, great, now we have this peds ER, I'm done, I never want to see kids again. Because honestly, we're a group of over 40 pediatric emergency physicians and 80 providers across the board, and we need those people every day seeing our kids. So again, it's been great to identify the people who are passionate about kids and want to maintain that as a part of their skill set, and to really provide them the resources to thrive. And so we've kind of carved out a group of maybe 20 to 30 people who kind of routinely staff the ED. Next one. So it's really important to, to do your homework, but the resources are out there. Next one. I don't know how Marianne got Noah Wiley to speak, but that was pretty cool. So, we're grateful to, to obviously, to forums like this and literature that's out there that serves as a roadmap. And believe me, I've spent countless hours pouring through this stuff. Next one. And everyone's familiar with this document. Next one. So yeah, like, I'll pick up the phone. Mark's there. Look at him, just waiting for the call. And Teresa is too, although we can't see her. But really, just as Sarah went on the road, I did too, and have really benefited from the wisdom of people that I look up to and respect. And people have been so generous. It's incredible how others want to see you succeed. So I've been overwhelmed by that. Next one. So be flexible, but stay the course. So soon after I came here, our health system, which was one hospital and one rehab hospital, started to explode in a good way, not implode, but explode. So you can fly through these next few slides. But soon after I arrived here, we purchased 5 hospitals. You can keep going through them. All kind of in southeastern PA. We began an emergency medicine residency program. Next one. We announced that we were starting a medical school in partnership with Drexel University. So in 2021, I think we'll have over 200 medical students with Reading as their primary medical school campus. Next one. And most recently, we purchased St. Christopher's Hospital for Children. So now we're a 7-hospital system with this wonderful opportunity to partner with an institution that has an outstanding track record for clinical care. So my point here, next one, is that, it takes a while, and the world will move on around you as you're trying to figure this out, and other priorities will arise, and we will feel like, the support has evaporated and you're all alone, and it's very easy to get left behind. And as I read that, I feel like I'm reading The Red Tree by Jay Tan, a book my kids love. But anyway, it's so true. And if you're unable to kind of roll with the punches and recognize that there's going to be highs and lows, then it's easy to become demoralized and kind of lose hope. So this is our quick timeline. I came in 2016. We wrote a business plan and submitted that, and we're actually funded. But it took a couple rounds to get funded. Sorry, my thing just timed out. But we went on the road. We visited other pediatric ERs around the region to kind of talk to people and see and learn from their experiences, to look at their plans and see what they liked about them and would improve. We tried to, sorry, as I try to log on again, we tried to engage the community in this process by sending out surveys, allowing them to provide input about what they see as being most valuable in the care of their own kids. We tried to incorporate that into our design. We even spent a pretty penny consulting with a proprietary company that specializes in kind of designing medical space, and that was absolutely worth it. So we began construction in November of 2018. Kara came in 2019. We opened last February, and quickly realized that we couldn't close at 2 in the morning. because of the demand, and now we're 24/7 with a child life therapist. Next. So this is the mailing that we sent out to over 10,000 families. We actually got over 500 responses. And then we used those people that responded to form a family advisory board that we look to continue to inform our care. Next. You can go through this, Mark. That's just our service area, and that's where people responded. So you can kind of see they match. We've gotten some grants. You have to kind of know where to find some money. We have something called the Reading Hospital Foundation, or the Friends of Reading Hospital. They'll support, endeavors for, $10,000, $20,000. We got a nice grant to purchase a Vecta machine to help with, distraction and for kids that have sensory processing issues. Next. Penn community is extremely generous. I think we've said that over and over. And we have participated in a lot of these programs that have brought SIM here, and that's been valuable. Next. And then, on a day-to-day basis, we're constantly calling other hospitals to help us work through, challenging clinical situations. We do have teleburn. We don't use telemedicine as much, although it's an organizational push. That said, we still transfer a lot of kids out every single day, and that's a gap that we're looking to close. Next. So, we're trying to help people thrive here. We don't want them to come into their shifts dreading taking care of kids. So we have really generously used clinical pathways and order sets to guide care. And one other thing that I probably should have put sooner in this slideshow is that it's easy to overlook the talent that you possess. And in places that you might not even expect, we have clinical leaders and champions in respiratory medicine. Our pediatric director of pediatric respiratory services has really like taken the ball with asthma and bronchiolitis and run with that. Our peds and ER pharmacists are instrumental in development of a lot of these guidelines. Our pediatric hospital group partners with us in developing things like quick and efficient admission processes. And then it's looking at like surgeons and subspecialists and saying, hey, who are we transferring out and how can we avoid this? Who can step up to the plate to fill the gaps? Next. And I do think it's important that we hold ourselves accountable. Using dashboards is really important, and giving the frontline staff the forum to kind of weigh in, speak up, and share their experiences about how we can improve. So you can just fly through the next 4, Mark. Okay, you took them out. Good. So that's perfect. But I had some slides about LWATs and length of stay and Press Gini and volume, volumes during certain times of the day, but track those things so you can see how you're performing. All right, last 2 slides. Thanks for your attention. The response from the community has been great. Hasn't been perfect. We hear from the community when we fail to kind of carry through with the mission of this pediatric ED. But I think they can see how much we care and they appreciate that. The buy-in from the staff's been huge. We've had great successes in certain quality areas, like reducing imaging and bronchiolitis. We've gotten our chest X-ray utilization from about 50 or 60% down to 30. Timely administration of steroids and asthma. We've historically been about 50. We're at about 75. We've become an asthma accredited center, JCO accredited center of excellence in asthma care. Low-hanging fruit like CTs for head injuries and right lower quadrant pain. Those are things that you can come in and pretty quickly start to change the trajectory. And then we've also worked with CHOP and HAP here in PA to do some more novel things like using EMR to identify patients at risk for sepsis. And we've actually already seen some improvements in time to fluids and antibiotic administration. So that's great. Next. A lot of the challenges overlap. And I want to give Kara just one more, a second to comment on this too. But, I think the hardest thing you need to overcome is that we have high acuity, but that high acuity is still not coming in, every hour or every day. It might be twice a week or, a few times a month. And it's really hard for people to gain comfort quickly when they're just not doing it too often. What do you think?
No, I just second what you said essentially, where it's the critically ill patient is the one that we're struggling with as far as competency because we don't see them as frequently. We're trying to put our nurses over on the adult side of the ER because they do see it a lot, just because of our sheer volume, and get them used to those critical situations. Chris or I are here. We're always present during those critical responses, just to try and coach them through the situations. I think we're getting better. I think we're improving upon things like location of equipment and knowing the room and knowing your resources and utilizing your resources within the health system and hospital. But it's just the teamwork dynamic, goes really well if we have Chris or our other pediatric emergency medicine locum in the resuscitation room that's running the resuscitation because they're familiar with the resuscitation of a pediatric patient. But if you get an EM doc that's not as familiar with it, then their nervousness kind of shows through, and I think kind of carries over into the nursing staff, and it doesn't always go as smoothly. So those are definitely things that we're going to have to work on moving forward. And Teresa and Chop have been phenomenal helping us out with coming up here with simulations. I think they've been up here 3 times, and we've definitely tried to utilize them as much as possible. I think it's been very helpful. I guess that's it. I don't think so. It looks like Mark was trying to talk, but I could not hear him.
Oh, shoot.
Mark, can you hear us?
I was muted as well. All right, I'm sorry about that. So you couldn't hear me either. There was a long pregnant pause there. I'm sorry. So I tried to unmute everyone. So there's a question from Katie Giordano. Do you feel you have buy-in from the other institutions because they're from the same umbrella of Geisinger and Tower, or do you think that outreach like this would be as successful if those hospitals were not directly in your health system? She's trying to work with community hospitals within Delaware, and she wants to try to get the same buy-in.
You want to take that, Sarah?
Well, if I'm understanding right, I think the way this works the best is relationships. And so do I get buy-in from other hospitals? I am a new person in this area. They don't really know me, but we take a lot of referrals from a lot of other places. It's sort of growing organically, where when I am in the trenches on the phone, I make a point of I personally make a point of calling 1 or 2 referral doctors back every week and just telling them what happened and thanking them, even though there may be a process for that. And I think that's going somewhere, at least that's my MO for at some point I'm going to be able to work on referral patterns and work on, there's competition everywhere, but an awful lot of this is I just want them to know we can do a good job of taking care of kids, and I want them to have some feedback as well, so that if they ask, what could I do to make this better, then I could say, well, gee, when you have this particular problem. So I don't know. It obviously, I think both systems, it sounds like we have a captive audience, right? It's more like a directive. Make this work, but I also think within my own system, I have people who aren't interested in helping me, and they can drag their feet, and that makes this work too. So I think it's developing relationships to make it work.
Yeah, and Katie, I would comment that trying to partner with your state EMSC, because I think that what we've seen in many states across the country are there community hospitals that really want this, and all we need to do is find the right sort of matchmaker to connect them with the academic medical center that's really passionate about this. So you don't want to force function. I think there's sometimes it's just not a good fit, but I would say whether it's partnering with your state EMSC or continuing to sort of date, I like to call it, have that first date with a couple of hospitals, and there are those out there that I think finding that right pediatric champion who's very committed is really critically important, and not, if it is not the right place or right time, not trying to force function. Another question that came from Teresa was for Sarah specifically, with the telemedicine setups within your Geisinger, who's responsible for answering the phone, and is it available 24/7?
It's just when Dr. Crowlin and I are there, because we're the only ones doing it, although I think a lot of people have kind of figured out I'm sitting in my office every morning. We're working 3 to midnight. You mentioned your hours. We have the setup with headphones and all that stuff in my office. As we're building this new space, it's actually going to be living in the emergency department. But what happens is we use Tiger Text, that's something I'd never heard of, that secure texting thing. So I get a text from one of the 2 other hospitals, and they say, could we telemedicine? And then I can look in Epic and see which patients they're talking about and say, yeah, I need a minute to run back to the room and get set up. And then we do it that way.
Excellent. So I did open the phone lines. Were there other questions that people wanted to either put in the chat box or had comments about? I'll ask a question specifically with having hospitalists here. I'd be interested to hear from both Sarah and Chris, what role hospitalists could play. So if there's a hospitalist who's passionate about this area and finds that there's challenges with the care of children in their emergency department, what would you say is a strategy to help engage with those generalist emergency physicians if there's not a Chris or Sarah in their system?
You want to go ahead, Chris?
Hey.
You want to take that, Chris?
I can't hear you anymore, Mark.
Uh-oh.
Okay. So Sarah, do you want to take that from your
Yeah,
perspective?
it sounds like my system might be a little bit different from Chris's, or at least our bylaws. I think the way to do this is to put what people call super pediatricians in your emergency department. And that is one barrier I've got, that I cannot convince these hospitals that I've got willing pediatricians, I've got willing hospitalists, I have really good hospitalists, and they've built the hospitalist program, and I can't quite figure that part out yet. Our hospital works with a transfer center, and I've actually been in talks with our transfer center and running numbers. The problem is, I have ideas, and then it's like, who am I kidding? It's going to be me or Jason, and there's 2 of us, so we just can't do stuff yet. But pulling hospitalists into this is exactly the way to do this, I think.
Excellent. And we'll end on that note. So thank you, Sarah and Chris and Kara, for your great stories. This webinar will be available online. The email addresses of the speakers will be sent out if you have any specific questions. And please, I encourage this group as a community of practice to reach out with questions. It's not the classic email listserv that we had in the past, but I think that using this group as an opportunity, I think that Sarah and Chris both told stories of leaning on some colleagues at children's hospitals and colleagues that were in community hospitals to have some shared experience again with that concept of a community of practice. So really outstanding sharing of your experiences. I can't believe how much you got done within a short period of time in both institutions. Perhaps coming in, you could shake up some of our children's hospitals, because it would take what you described 2 decades, not 2 years in both of your institutions. So thank you so much. And Sarah, best of luck. I know that you have a grandchild coming soon, and Chris, you have a 4-month-old at home. So lots of work to come for pediatric emergency care for the 2 of them. And thank you again, and have a great day, everyone. I really appreciate your commitment to this work and your time.
Thank you.